Good evening, everybody. Welcome back to another webinar. It's the very first time we are doing actually aesthetic medicine. Aesthetic medicine has become a big part of medicine these days compared to when I started doing medical school and even when I practiced as a doctor. And I'd like to welcome Dr. Christina Chia. Dr. Christina Chia, actually, Christina and I went back a long way. When I practiced in, we practiced in Hospital Tar, right?
Yes.
For a short while, and then she ventured out into aesthetic medicine, and she actually has done very well. She does a lot of training. Okay, without further ado, maybe we allow Dr. Christina Chia to speak.
Yeah. Hello, Betty already introduced me. So I practice aesthetic medicine and anti-aging medicine for a long time, and I at my practice in Sabah Jaya, and we are into our 15th year. So I have special interest in injectables, especially dermal fillers and botulinum toxin. I also train and teach for MAC program, for Teoxane, for Powers, for Dysport, for Triple AM, and for other groups as well. So thanks to Betty today for me to share my experience, and I hope it'll be a useful session for all. So today our topic is anti-aging therapy for GPs, right?
Yeah.
Okay, so anti-aging is a very broad topic. It's very general, so there's so much to talk about, and I'll try to cover as much as possible. But today I include the topics which are listed, or the treatments which are listed in the LCP for chapter 1, means for GPs, right? Okay, so anti-aging is more than just science. So the ultimate goal, whatever it is healthy aging. So we want to feel good and look good. So really, the reality is people want to feel good and look good. Yeah. So we want to reduce the chance of developing anything aging related, whether it's disorders or even cancers. And because we want to extend a healthy lifespan, and most of all, it's quality of life. We want to feel good and look good, right? Okay, so it's a holistic approach which involves all the specialties in medicine and the synergistic effect. And so it actually includes not just beautiful skin and not just good skin and anti-aging on the skin, but it also includes nutritional therapy, exercise, and mental well-being, and taking the correct supplement, including hormonal replacement therapy. I'm a firm believer in bioidentical hormonal replacement therapy, only bioidentical. I'm not into synthetics, yeah. And why do I believe this? Because hormones have a big roles, and as we age, our hormones will go down, the functions also will go down, so they'll decline. So that's why the replacement is important, right? And also taking the correct vitamins. I don't believe in taking a bunch of vitamins and minerals and all, but taking the correct supplements and at the right time for the right people would be very useful. It is also a big part of anti-aging therapy, right? Okay, so don't forget that we also need to have healthy nutrition, not to be sedentary, and manageable stress and good sleep, especially. So I always tell all the ladies, if you want healthy aging, you must sleep well. All right, so now let's come to skin aging, yeah? So it's a combination of intrinsic and extrinsic factors. So intrinsic would be chronoaging, chronological aging, biological aging. There's a lot of endogenous oxidative stress. So the keyword is oxidative stress. So produces all these free radicals, yeah, that contributes to all the wear and tear and degeneration. And of course, cells are dying, and then there's hormonal changes. Usually they're on declining mode. And of course, bear in mind there's ethnicity and anatomic variations. Okay, whereas extrinsic means external factors. So you guys know, lifestyle, smoking, pollution, and one of the biggest factor will be photoaging, right? So extrinsic, naturally occurring over time, but intrinsic, and extrinsic factors to some extent manageable and avoidable, preventable. Yeah, so this is what we can do a lot. Yeah. Okay, so chronoaging, slow, irreversible tissue alteration over time. It's said that it's irreversible, but we can actually reverse, and we can actually slow down or reverse all these changes, right? And of course, what are the changes? So we have reduced elasticity, less hydration, radius.
I don't believe just the leakages and the corruption will help address.
Yeah,
I would appreciate if you all can mute yourself the moment you come in or even before you come in, yeah? Okay.
Yeah. Okay. The extrinsic factors and together accumulative extrinsic factors on top of your chrono aging, so that will give you a lot of skin aging, yeah. So especially UV aging, UV exposure, which is photo aging. So all these, there will be an increase in RS formation, reactive oxygen species. So all these factors, lack of sleep, especially not just pollution but also photo aging, all will lead to RS, reactive oxygen species. So that means all the free radicals. So remember, free radicals are the ones that contribute to aging. That is why I believe in taking supplements as well, the correct supplement, not a bunch of other supplements which are not important. Because if you take too much of not necessary supplements, you actually can gain weight unnecessary, right? So nobody wants to gain weight at this age. Okay, all right. So photo aging, you know, UVA and UVB. At the moment, we are protected from UVC, and this will lead to a lot of premature skin aging. All right, and of course, your folds will increase, the loss of facial contouring. So look at the difference. Look at the histology of the young and healthy skin versus an old skin, right? Okay, so aesthetic treatments or anti-aging treatments should be tailor-made for specific patients' needs. Yeah, it's not a standard move for everybody. Okay, now let's look at microscopic level. So what happens? So you see, you have your epidermis and dermis. So epidermis gets thinner, and then in your dermis, you have your extracellular matrix, ECM. This is a very important component in aesthetic medicine because it has all the important things that you want. Your GAGs, your glycosaminoglycans, especially hyaluronic acid, there will be less production, so loss of volume, loss of hydration, less collagen, less elastin, so your skin loses its elasticity, so there's more skin laxity, right? So how do we fight skin aging? So optimal is always a combined approach. There is no one single treatment that can fight skin aging, right? So we need to target all these three. So your chrono aging, your extrinsic factor, the most important is the photo aging, and also how to treat all these smooth lines, right? And the wrinkles. And aging process is always multi-dimensional, right? So aging is multi-dimensional. So you have all these features, and the wrinkles are always perpendicular to your muscles, right? So if your muscles are going vertical, the wrinkles will become horizontal. And of course, with advancing age, so we lost our full, we will lose our facial fullness, the suppleness, and then there's a redistribution of subcutaneous fat and skeletal structures. So there's a lot of bone resorption, and with the effects of gravity, so we have stosis, right? Okay, so what's the concept of beauty, right? So in 2009, Hofflin mentioned this definition that is condensing all the previous definitions of facial beauty. A beautiful face combines facial features that are attractive, shapely, balanced, elevated, symmetrical. See, we have to be symmetrical and in volumetric proportions. So of course, it would be better if we also have a healthy teeth, hair, and skin, right? And we cannot reduce the concept of beauty to a standard template. There's no one standard template for beauty. It is also defined differently by different ethnics and cultures. And the concept of beauty is always changing, it's always evolving. And therefore, what is beautiful today may not be tomorrow anymore, right? Okay, so when people talk about the Leonardo's rules, the harmony of the face, so this is the famous 5 rules for facial proportions mentioned by Leonardo da Vinci, between the eyes and the mouth, nose, and the top of the ear, below the ear. So these are the rules of face. Yeah, and then now I'm going to talk about anti-aging therapy for GPs. So these are the topics, these are the main topics and the treatments that are allowed and listed in the LCP, licensing and credentialing privilege for chapter 1 for GPs. Yeah, so much to cover here, so I try to go as much as I can, right? Okay, so now we come to botulinum toxin A. This is one of my favorite treatment. I train a lot for this, especially for this part. Okay, I'm not particularly for any brand, but it's just the brand that I commonly use. Okay, so botulinum toxin is the miracle poison. It's the most poisonous biological agent. So you all know it's anaerobic, gram-positive, spore-forming, rod, Clostridium, and there are 8 types, but all of them have the same action, which blocking the release of acetylcholine, which is the main neurotransmitter for your NMJ. So now you have your muscle paralysis or weakness, depending on the strength that you use, and the duration will last about 3 months, plus minus, and there's a lot of medical and aesthetic indication, and the list is still growing. Right? So the list has even reached not just the face, but it's reached even the scrotum as well. So you must have heard of the word Scrotox, right? Okay, and finally in 2002, FDA has actually approved BTA for cosmetic indication, but for glabella, all right? Okay, so The molecule, light and heavy chains, just know that the one responsible for the toxin effect is the light chain. So this is the structure, and there are 3 steps in causing the effect. So binding, internalization, and inhibition of the acetylcholine release. And okay, so let's talk about the brands in Malaysia. So these are the 3 key brands that are registered in Malaysia. So currently there's an influx of a lot of Korean Botox, Korean BTAs and China BTAs as well. So if any of you want to use this brand, so make sure that they are safe and they have some kind of backups, and also they are registered most of all. Okay, make sure they are registered in Malaysia. So these are the 3 key brands: your Abo, which is Dysport, your Ona, which is Botox, and Inco, which is Xeomin. Okay, so just a quick summary for all these 3 brands. Just ignore this brand because it's not found in Malaysia. Despite the differences, they're all acting on SNAP25. Yeah, so they have different molecular weight. And for Ona, Botox, and Abo Dysport, both of them are actually botulinum toxin complex, but Inco is actually free from complexing protein. So this is their main selling point, right? But it doesn't mean it's always an advantage, but anyway, it's their selling point, and they have different molecular weight, and they're all FDA approved for the same reasons. And these 2 need to be free, but for Xeomin, it can be put in room temperature. And these are the dilutions if you guys want to learn. So normally this pot is standard 500 units. Ona and Inco, they come in 100 units. So all of them using 2.5 ml dilution. This is the standard dilution, all right? And for those who are used to Botox and Xeomin, so they are almost equivalent. 1 unit is 1 unit equivalent. So if you want to know, unofficial conversion to this pot is 2.5. So 1 unit of Botox or Xeomin equivalent to 2.5 of this pot. So this is not for exam, but this is just unofficial conversion. Okay, all right. So this is just dilution. So normally when we dilute, we use a bigger syringe, and when you inject, always use the small syringe. So always use from 30 gauge onwards. You can use 30, 32, 33, right? And try to use half-inch syringe. And of course, the results will come in usually by 72 hours. On the 3rd day, they will start to feel, and maximum will come in at 1 to 2 weeks. That is why we do not top up or we don't follow up until 2 weeks, right? Because by then you will know what's the maximum results. And duration 4 to 6 months plus minus, averagely 2 to 3 times a year, right? And interval, I try not to give less than 3 months, because if you give too frequent, you can encourage the formation of antibodies, although it's rare, right? Okay, so the indications, so these are under neurologists, but whereas for aesthetic, actually officially only approved for actually hyperhidrosis and glabella lines. So everything else is actually off-label use, but it's been so well established and all the doctors are using it, so it's okay, although it's actually off-label. So you'll be surprised that all your crow's feet and also your forehead and your masseter, they're all actually off-label indications, right? Okay, for actually hyperhidrosis, this is a very good thing to learn because it is very useful. Those patients who suffer from this, they will know. So they have sticky, moist armpits, and then they may have body odor, they may have stains. So it does wonder for them. And those who have done this, they'll always come back for it. And the effects getting longer and longer with each successive injections. And their armpit becomes dry and matte and is very much comfortable for them. So it's actually really useful because they're suffering from the stigma of this sweaty armpit, right? Okay. And of course, all these injections, they will have contraindications. So normally it will be all the neurological conditions, and of course pregnant ladies, lactating women, and those infection at the injection site, allergies or aminoglycosides. All right, so what are the aesthetic indications in Malaysia? So of course, like I said, it's officially approved US FDA and also in Malaysia for glabella lines, but the rest are okay, they're just off-label users. So what do patients want? Not just what we want, but we need to ask, what do patients want? So they want to look refreshed, okay? So some of them want to look fresh, healthy. They want to improve their self-esteem, self-confidence. Yeah, so like I said, when you look good, you feel good. Yeah. Okay, so some want to look natural, some actually want to look beautiful, some want to just have no wrinkles, and some just want to look better than their peers. So it depends on what patients want. You will see different patients have different needs. Yeah, so aesthetic indications. So let's go through quickly. These are the common aesthetic indications. So these are the glabella lines. So before and after, forehead lines, and of course, your lateral canthal lines, or what we call crow's feet. And then we have more indications like your posterior platysmal bands. Yeah, so you see, this makes the patient look old. Yeah, so when you take away all these bands, so the patients actually look less haggard, less harassed, yeah. And of course, very good for those with broad square masculine jawline, so we can actually reduce the masseter. And so this is what we call facial contouring or facial reshaping, right? Okay. And then, of course, there will always be some contraindications. So those with very saggy skin, excessive eye bags is a no-no. And those with very deep static wrinkles, means wrinkles that present at rest. So you need, they work to some extent, but you need to combine with other modalities. Okay, so adverse reactions, I think all you guys know all the standard injection pain, hematoma, headache, localized dryness, but they're not common. But beware of eyelid ptosis. Yeah, this is one nightmare. But if you practice enough in the beginning, maybe you will have one or two this kind of complication, but learn to treat and assure patients. And remember, you attend patients and you understand and you correct for them. Of course, you don't charge for the correction, and they'll always forgive you. And then you learn from the mistake, and they will still come back to you because they know you care and you're responsible for the mistakes that you do. Because this one inevitable, sometimes it happens. Yeah, it's because the diffusion of the BTA into your LPS, levator palpebrae superior muscles, and of course, it happens especially when you inject orbicularis oculi, your corrugator, or your procerus, and usually they will come just like the onset of your BTA, which is within the first week, and it can last you for a few weeks. But thankfully, we have something to treat, which is aproconnidine, and it works because it stimulates it contracts the Mueller's muscle, so it can elevate back your eyelid by 1 to 3 mm, so it helps, right? So to prevent this from happening, you can actually make sure that your injection for the forehead is at least 1 cm above the orbitarium, so that'll be safer. Or you inject only the upper 2/3. Okay, and ectropine strabismus, they are very rare. When this happens, you have to refer to your ophthalmologist. Yeah, okay, these are very rare as well. And about Mephisto sign or Mr. Spock, that one I'll come to that later. So when you want to inject BTA, you must learn the muscles of your face and neck, because you understand the muscles, incision and origins, and so the actions, and you will notice that there's a balance between your elevators and your depressors. So the working force between both of these, then you understand what to do to get the results that you want. So these are the muscles that you need to learn when you want to practice BTA. Okay, and remember the lines are always perpendicular to your underlying muscles, and these are the main muscles that we want to learn for the main indications of botulinum toxin here. Yeah, so remember all your anatomy. Yeah, so these are, okay, look at the actual anatomy. So to frontalis, we think that it covers the whole forehead, but actually there's emptiness here in the center. But sometimes we still give one injection here because of the diffusion, right? Okay, so these are the key muscles for upper face. So frontalis for your horizontal forehead lines, corrugator procerus for your glabella, and orbicularis oculi for your crow's feet. Okay, and these are all the standard indications as well. And of course, make sure patients have realistic expectations, and judging both patients' expectations and correct them when necessary, and your own clinical judgment, so you have a treatment plan. And always look at patients' facial anatomy, very important. Don't get caught, yeah? So always check them and take photographs at rest and at movements with facial expression. Observe these two and look out for pre-existing asymmetry. Please look out for this, record, take pictures, and inform patients, because the patients will never know. But after you touch the patients, whatever that were pre-existing will become magnified to them, then they will blame you. So you must always inform any pre-existing asymmetry. Inform them and tell them, look, you have got this. And then tell them how much you can help and how much you cannot help. So make sure you tell patients all these things, so they will not blame you for this, all right? Because patients become hypersensitive to whatever you have done to them after that. They'll magnify everything. So they think that the changes are caused by you, right? Okay. And then patient selection is very important. So you have to differentiate between hyperdynamic and static lines, because static lines already present at rest. So you cannot completely eliminate with just BTA, right? And photography and consent. So whatever you do in aesthetic medicine, photography and consent are mandatory. You must have these two, right? Okay, and of course, make sure, because these are injectables and multiple points, so all your blood thinning supplements and drugs, if you can, you stop at least 3 days or 1 week beforehand. But in some patients, they can't stop certain blood thinning, so then you have to be extra careful. And of course, post-treatment, mainly we want to reduce swelling and bruising, mainly. So of course, you can use like cold compressed ice pack, and you give them some post-procedure cream and a very good those that contain vitamin K and arnica, and of course for at least 2 days, tell them not to do any strenuous activities because they will actually cause more delayed bruising, right? Okay, like I said, informed consent of photography is very important. And okay, these are the 4 key muscles for your upper face, your upper third of your face. And in terms of how deep they are, so the deepest will be corrugator, and the most superficial is orbicularis oculi. So when they're so superficial, you can actually inject superficially. You can actually inject with a bleb, that means intradermal. But corrugator, you cannot do that. You must go deep intramuscular. Okay, right. So now let's look at forehead line. How do we do? So generally there are 5 to 4 points, and the medial points are along the medial canthal lines, and the lateral points are along the lateral canthal lines. And in women, usually we give them a little bit of curve because we want a bit of lifting of the lateral eyebrow. Okay, and you can always draw a line and make sure you avoid the lower 1/3. So your injections are mainly focused upper 2/3. Why? Because you want to avoid lead ptosis. Okay, this is the complication that I talked about, Mephistocyte or Spock, Mr. Spock. How many of you actually remember Mr. Spock? Those who are like me and Betty, we know, right? Yeah, those were the days, but the younger ones probably not heard of Mr. Spock, yeah?
No, I'm sure they do. No.
Yeah.
You have heard about this before.
Okay, I really would appreciate if everybody comes in and just mute yourself, okay? Because it is very, very disturbing when you suddenly come with your background music, your background sound. Sorry about it, Christina.
That's right, it's okay. Yeah. Okay, so this is Mr. Spock. Yeah, so remember, so this one you don't want this because they'll be like staring at you and they look so fierce. So remember, when you first start Botox toxin, remember you must be very careful if it's your early days. And also if the patient is their first time, because if you do mistakes, you can actually change their whole outlook. Remember, you can change their look, you can change the shape of the eyebrow, and that's it. You change the entire expression. So be very careful. Be very, try to be as natural as possible. Yeah. So when this happens, so actually the point is actually caused by under treatment here. So what we do, we just add a little bit more treatment, a low dose, a bit higher on the point, higher on the point of maximal contraction, on the point of the maximum lifting here. So just put a bit, then it will soften the lip. So then it will come down a bit. So it doesn't look too Mr. Spock, right? And actually forehead looks like an easy area, but it's actually the most difficult area to get exactly right. So you will learn along the way, because this is a very narrow window. You need to compromise between lift and lines. If you give too much, you reduce the lines, but you eliminate the lines, but you reduce the lifting effect. But you want more lifting effect, you might not be able to reduce the lines. So you need to compromise and achieve a balance between lift and lines, okay? And when brow ptosis happens, there's nothing we can do, so just reassure, okay? All right, so now we come to glabella. So to understand glabella before you inject, there are multiple patterns of glabellar lines. So you have U, V, omega, converging, anti-omega, centrifugal. So look at the real ones. So actually you can see the procedures, and you can see the corrugator here. This is the head and the tail. I call them head and tail. Actually it's the medial and lateral. So you see medial, lateral. So this is the corrugator. So this one also, and you see this one is the medial and lateral corrugator. So when you catch the muscles, that's where you inject intramuscularly, right? Okay, so these are the injections. So normally standard minimum is 3 points, 1 on each corrugator and 1 procedures. But if you include the tail of the corrugators or the lateral part of corrugator, there'll be 5 points. So it'd be good 3 to 5 points. Yeah, so the middle corrugator is always deep. So your injection is almost on the bone. But when you go lateral, so you go not so deep. And procedures, of course, is deep, right? And always put your fingers here. You actually ask patient to frown, maximum frowning, and then you catch the corrugator between your fingers. So one finger is on top, yeah, and one finger is actually at the bottom. So you're actually at the bottom here, so you protect your lower brow. So you really protect the lower brow so that you reduce the chances of diffusion into the via the orbital septum, because when they go in there, you get lead ptosis, right? Because there's nothing you can do with lead ptosis except for the acrocondylene, and you have to wait for the effects to run to fade off, right? Okay, so how do we get the posterior point? So you draw 2 lines from the middle canthus on each side to the opposite middle brow, right? So the intersection will be your lowest point of posterior injection, right? Okay, so what are the complications? When you want to learn injection, you have to learn to treat the complications as well. So these are the 3 main ones: upper eyelid ptosis, middle brow ptosis, and periorbital edema. Okay, upper eyelid ptosis, like I said, is migration of the toxin through the orbital septum, so it affects your LPS. And so you have to make sure that your dilution is correct. Some doctors actually dilute more because maybe they want to save cost. But if you do correct dilution, it will be more correct concentration. So there will be less unwanted diffusion. Okay, so less unwanted diffusion, you are safe. So the botulinum toxin stays where you want it to be, right? Okay, and so how do you treat this when it happens, which can last for a few weeks? So you treat with aproclonidine, all right? Okay, and periorbital edema is caused by, okay, after injecting all these areas, you notice that the patients have a risk periorbital edema. It become more baggy and more puffy. The reason because we cause the lymphatic stasis because we have weakened the sphincteric pumping action of the orbicularis oculi. So remember, patients with very high skin laxity and very excessive eye bags, these are the relative contraindications. Yeah. Okay, middle brow ptosis also can happen. Yeah, and this was because we hit the middle corrugator too much, or because we injected the medial lower fibers of the frontalis. Because they actually overlap. The frontalis and the middle corrugators, actually they overlap. And remember, your frontalis is the only elevator for your forehead. So if you knock it out too much, there's nothing else to elevate already. So there you have your middle brow ptosis, right? Okay, so now we talk about crow's feet very quickly. So there are normally 3 points, and the points must be at least 1 cm or 1 finger breadth away from the orbital rim. And the lowest point cannot be too low because you don't want to hit the zygomaticus. Once you hit, patients will not forgive you because they will have asymmetrical smile, right? Okay, anything you do, but don't cause asymmetrical smile on patients, right? Okay, so for those with very long, extensive crow's feet, you can have extended points, right? Okay, so there's one final conclusion about botulinum toxin. It's a very easy skill to acquire, but very difficult skill to perfect. Especially so the forehead also. Like I said, there is a very narrow window for you to play to compromise between lift and lines. Okay, all right. So these are something special, extra functions of botulinum toxin, which works very well with ARBO. So I have a quick run through because some of you might be interested. And actually, I do practice this, and they are actually very subtle, natural, and very useful. And patients love it. So it can do three types of lifting: your lateral brow, intradermal, and a fatty T lift. Yeah. So lateral eyebrow lift is very easy. Just 2 points, and 1 point on your tail of the eyebrow, and 1 more point on a bit more medial to the first point, and on the upper side of the frontalis. So these 2 points will give you lateral brow lift, right? And the next one is intradermal lifting. This is the one that you hear people talk about, mesobotox, dermal lift. This means the same. It is actually intradermal lifting, right? So it's been published in Journal of Cosmetic Dermatology by Prof. Sima and her team, and they actually did a split phase randomized trial. One side normal slide, one side ARBO, and you can actually see very good results. Yeah, so you actually inject 1 or 2 cm apart, and you actually inject and cause wheals. So very superficial, you create a black. Yeah, if you don't create a black, it will not give you the result because it has gone into the subcute. And it's 1 in 7 dilution. The standard dilution 500 is with 2.5 ml, but for purpose of intradermal is 7 ml, right? And like I said, injection always 1 cc syringe. Why? Because smaller space, so you have less pressure. So also you can control better the volume that you want to inject. And the gauge always 30 to 33, right? The smaller the better, and total will be 50 to 70 units per side. And this works particularly well with ARBO toxin, and also works with Inco botulinum toxin. Not so much with Orna botulinum, right? Okay, and so you can see the result. So look at this before and after. You can see very good result. This is just on intradermal lifting. Yeah. And you can see before and after. Some of them even have immediate lifting, but the best results come in at 2 weeks, and it can last between 3 to 4 months, so about 10 to 14 weeks, right? Okay, so Prof. Charia, she's a dermatologist in Bangkok, and she has mentioned that, the fatty lift technique is so popular those days that even until now, the fatty lift is very good for all the posterior bands and also for jawline contouring. But this only works when the patients have very visible or well-defined posterior bands, baptismal posterior band. So for some patients, you can't find the posterior bands. Like me, I can't get it. So, but they have a lot of skin laxity. So these are the patients who become good candidates for intradermal technique instead of Nefertiti lift. Because for Nefertiti lift to work well, you must be able to have well-defined platysmal bands, right? Okay, so now we come to Nefertiti lift. It's also published in some journals. And so 500, this is according to normal botulinum toxin dilution. So 2.5 cc sterile saline and 30 dH 1 cc syringe, and 4 injections on the mandibular border, about 1 to 2 cm apart. And this one you can go into subcute. And of course, on every platysmal band, so you have a vertical series of 2 to 4 injections, 2 cm apart. So total will be 120 or 125 units maximum for the global neck treatment. In fact, this is very good for neck treatment. This is one of the combined modalities for neck rejuvenation. Right, so we can see before and after. See how it changes the jawline here, and also see the marinade fold. You can see the reduction here before and after, and you see all these bands. So it has reduced, because when all these bands come out, the patients actually look relatively less healthy, and also more harassed, more stressed. Yeah, so when you take away all these bands, the patient look more relaxed, right? Yeah, and see the difference before and after. Yeah, so and the jawline here and here. Now the jawline becomes more well defined. Okay, so let's talk about combination. Most of the time we need to combine botulinum toxin and dermal fillers. Why? Because aging is complex and it's a dynamic process and involves bony processes, muscle, ligament, fat, skin. It involves every layer from bone to skin, skin to bone. So all these aesthetic treatments, when we combine them, they can actually complement each other and they can be synergistic. And why? Because we have toxins to relax the muscles, so we can relax the wrinkles, and then only we fill up all the deficiencies or all the volume loss, right? And fill up the wrinkles, and also we can enhance skin density. So this is what we call all the very soft fillers. We call them skin boosters or biostimulators. These are mainly for surface rejuvenation, for skin density. Right? Okay, so why do we combine? Because it can give you greater efficacy, better patient satisfaction, and better lasting result. Okay, when you combine these two, which one do you do first? Okay, in two scenarios, if you do in separate sessions, you always relax the muscle first, yeah? Because then your fillers will last longer. So you start with toxin, 2 weeks later, only you fill up your fillers. So your fillers will last longer because now your muscles do not keep contracting them, right? But if you do in the same sitting, you will have to work from deep to superficial. So everything deep you do first, and finally you do the superficial. So you start with filler, and then toxin will be the last, okay? Also, in case if you done Botox before a filler on the same setting, and when you have a vascular occlusion complication, you need to high-lace the patient. So the high-lace will mess up your toxin. It will cause diffusion all over. Then you can affect the raw muscles. Then you'll be in trouble, right? Yeah. So, okay, combination treatment also can do with other types, whether it's laser, fillers, threads, or chemical. For most of them, like laser, fillers, and threads. So we always on the same, this is talking about different setting. So we always relax the muscle first. So we BTA first, and then we do the procedure, the other procedure second. Except for chemical peels, we will peel first, followed by BTA second. Okay, so now we come to dermal fillers. Yeah, so this is a big topic, but I try to give the important things. And for beautiful, to define beauty to be achieved by fillers, remember that our face needs to have a character, so it needs to be soulful. We cannot just be a standard mold, otherwise it's just a plain face, right? And always bear in mind there's always differences between Caucasian and Asians. For Caucasians, they typically have this very obvious triangle of beauty. Their faces are long and narrow, whereas for Asians it's typically, not always, wider face, prominent zygoma. Anyway, there's no gold standard. Always remember, there is never a gold standard or ideal facial shape. What is good in one country or ethnic may not be favorable in another ethnicity, in another ethnic or country, right? So we need to customize treatments for every individual, right? And this is what we call facial design. So you're designing if you design a facial treatment plan for patients, where to inject what, right? Okay, and do not create a stereotype, okay? Because it's bad. You don't want to make everybody looks the same, and because there's a lot of individual beauty in diverse appearance, and also sexual dimorphism. These are differences between male and female. And always for facial assessment, we keep it simple. Okay, I need to mention these few rules so you understand what to do. There are two types of aging process: implosive versus explosive. Implosive will be 80% of population, so they're actually losing volume. So it's good, it's easy. Not to say it's good, but it's better than explosive because it's it's easy. When they lose volume, we just replace the volume. It's so much easier. And when you replace, you actually make them look more supple and younger, right? But when it's explosive, which affects 20% of the population, means their volume actually increase. You notice some patients, as they grow older, their nasolabial fold, their jowling becomes heavier. It's so much heavier and the folds become deeper. So when it's so heavy, this kind of patient, you can't inject too much filler. So if you want to treat with BTL filler, they need very small amounts. So different from the implosive type of patient, because some patients don't understand. They see very deep fold here in the nasolabial fold, very deep, and the explosive type, and then they think that you can just put filler, just put a lot of filler in the fold and solve their problem. But you can't do that. The more filler you put in the fold, they actually go, because of the dynamism of facial movements, they'll actually go more into the fold, nasal fold, and it becomes worse. So these are the patients that we can't do fillers at those areas, right? And those patients actually will benefit from some localized fat reduction or skin tightening devices, right? And remember the rules from the front. When you view the patient from the front, remember rule of fifth. That means you divide the face vertically into 5 portions, and the rule of thirds means you divide the face horizontal into 3 portions. Yeah, and look out for sharp angle, and always view patients also from 45 degrees. So you must have the OG curve. This is the famous OG curve. All the aesthetic experts globally will talk about. We want to achieve OG curve. The OG curve is a bit like a S, so you have this nice curve, right? And also look out for potential problem patients. So these patients can be problematic, and especially patients come and complain about your next door, your competitors, your colleagues. So these are very dangerous patients. So you have to watch out, because you might be the next victim. Okay, all right. So always remember to ask what patients want, because what you see sometimes they don't see, and what they see you don't see. So always talk to them and make sure you manage their expectations. Okay, so for younger patients, normally with fillers, they want more beautiful. So they want to change their features. They want to change their nose. They want nose augmentation, lip, and also chin augmentation. These are what they usually want, because they don't have much other aging changes. Yeah. Whereas the older patients, normally they don't want to change anything drastic. They just want to restore what they have lost. So bear in mind, most of the time they only want rejuvenation. So don't give them something so drastic, because they cannot accept, even though you think they look good, right? And sometimes you have to make sure they're very natural and suit their personality, and make sure the keyword is harmony. Make sure they maintain facial harmony. And of course, patients are very scared of those standard stereotypes, like it's to give way that you have done something. Oh, you overdid it. Like, you know, you have a deformed face, fixed stare, and you look inflated. You have a pillow face, pillow cheeks, because it's overinflated. You have these golf ball deformities when you smile, because there's just too much filler in the wrong layer. Maybe it's given in a too superficial and too much. So you have these golf ball deformities when you smile. So don't do that, right? So when we talk about fillers, we also must remember to inject the correct product into the correct level or correct plane. That's why anatomy is important, right? Okay, so there are some studies that show what are the top filler indications in the market. So you look at the list by patients requested, and also the list done by doctors. So you notice the top 3, although in different sequence, always talk about periorbital, tear trough, perioral, and mid-cheek. But for patients, they always ask tear trough, because that's what's visible to them, and perioral. They'll never ask for mid-cheek so much, because it's not visible to them. But for doctors, mid-cheek becomes top of the list. Why? Because we understand mid-cheek is the first area that undergoes aging. So most of the time we correct mid-cheek, it already improved the tear trough and the perioral region. So we don't have to do so much anymore for the tear trough and perioral. That's why the mid-cheek becomes the top. So later I'll run through these 3 areas for quick one, so you understand and see some pictures as well. Yeah, because these are the top 3 indications for fillers. Right. So like I said, we divide the face into 3 compartments: the upper third, the middle third, and the lower third. So upper third, you have temples, forehead for fillers, and you have your glabella, cruise-fit eyebrows for botulinum toxin, and then your middle third is your mid-cheek and your tear trough area. So this is the most important area, and also cheekbone, your nasolabial fold. But conventionally, patient always come, I want to treat my nasolabial, but the trend is not nasolabial, because we know that there's a lot of mid-cheek deficiencies and a lot of deficiencies in the malar areas that lead to the nasolabial fold. So the more we inject nasolabial fold, actually becomes more heavy. So we actually correct the mid-cheek here to improve the nasolabial fold. And then the lower third is talking about perioral, very important, not just lips, but also the perioral areas or the barcode lines, and also your corners of the mouth with the married fold, chin and jawline. Okay, and of course, overall, don't forget the overall facial skin quality. So that's where all the skin boosters, skin biostimulators, good skincare, and all the supplements will come in, because you not only want to correct the contouring and the volume, you also want to have very good skin quality. And don't forget the neck and the décolletage, and also all the horizontal neck creases, because they become deepened with aging, right? And don't always just focus on the face. We make sure that we balance the neck as well, because if we do too much on the face but we forget the neck will give way, right? Okay, and always bear in mind there's a lot of cultural beauty, there's a lot of diversity in cultural beauty and ethnicity. So what is good in one culture may not be favorable in another culture. So look at the variety, the variable differences in the different cultures, in the different definitions of beauty in the different cultures, right? And look at these very shocking trends. So some trends, like these lip trends, are very famous in some places, but it's literally no in our Asian community, right? And most importantly, people don't want to look plasticky or unnatural. So this is a big no, right? And so these are the things that we want to avoid. These are all the fillers, wrong techniques, bad techniques, and bad products as well. Okay, so before we go deep into fillers, always remember this triangle of youth. When you are young, look at this, your triangle youth is here, it's pointing downwards. Yeah, so it's more triangular like this. But as we age, there's actually inversion. So it become inverted. So now it become broader on the bottom of the face. Yeah. So this will give rise to a lot of negative and unwanted expressions. So you look tired, you look grumpy, you know, you don't look good, you don't look pleasant, right? So okay, so when we talk about aging in terms of fillers, you have to remember in 5 layers: skin, superficial fat, muscle, deep fat, and bones. And changes will occur in all 5 layers, right? So your skin gets thinner, changes happen in the muscle, bones also gets resorbed. So these are all the standard bone changes, bone resorption. And let's talk about what happens to the fat. Changes in the subcutaneous fat. So we have superficial deep fat pad. We have also deep fat pad. The deep ones will lose volume, whereas the superficial fat pad will actually increase volume. So it goes south, because when you increase, becomes heavier, and plus gravity, they just go south, right? So this is what we call fat redistribution caused by accumulation or atrophy. So the atrophy usually occurs in these areas, and hypertrophy usually occurs in these areas. Famously, your jowl, your submental, your double chin, and of course your nasolabial. So that causes the laughter line, the smiling line, right? And the superficial fat compartments, in summary, generally will undergo hypertrophy. So they become heavier, and because of gravity as well, they slide downwards, and the deep fat will lose volume, they will atrophy. So you lose the support for the overlying tissues. So that will aggravate again the downward movement of your overlying skin structure. So this is what happened. So when you understand the changes like this, so you know how to correct them and reverse them and put them where they belong, right? Yeah, so for deep fat, we want to restore volumes, whereas for superficial fat, we just want to restore the lines and improve the folds. We don't want to add any more volumes. So the type of fillers that we choose is also important, right? So again, so for superficial fat, the fat is always a dynamic layer, means it is mobile layer. This is the one that responsible for our natural facial dynamism, facial movements, facial expressions. Whereas the deep fat is static, it is stuck to the bone, it's immobile. Yeah, so that's why we can use the standard rigid fillers here, because it's mainly for projection lifting to restore volume. Whereas for this superficial fat, we try not to give the stiff volume, because that will make you have a stiff smile. So we have to use dynamic fillers. So at least fillers which are more malleable, resilient, more dynamic, so they adapt to your natural facial movements. Okay, all right. So remember, your fat is just not homogeneous chunk of fat like a piece of butter. No, it's absolutely not. It is actually in compartments and layers, right? So look at this. So like I said, your superficial fat pad, which is dynamic, mobile, gives you your facial dynamism, and you have your deep fat, which is static and not mobile. Yeah, so when you treat the deep fat, you restore the volume. So you use a stiff filler. But when you treat the superficial fat, you must use the dynamic fillers, which are adaptable and more malleable, right? Okay, so they're also compartmentalized. See, your fat is actually compartmentalized. So this is what we call 4D. So not only layered, but also compartmentalized. So this is what we call 4D anatomy. So very important for deep compartment. These are the famous important compartments which we use to restore volume for patients. These are where we inject the fillers. So with the medial soothe and lateral soothe, very important compartments to fill up, and this will literally improve the facial contouring, your mid cheek, and also improve the tear trough. And also when you leave this area, you actually improve the jawline, the jaw, the manifold, and also the laughter lines. And then these are your superficial fat, and they actually hypertrophy don't increase, so it's a no. Like here, nasolabial no, yeah. And like here, this is a good entry point, so you can fill in the lateral soothe and medial soothe. Soothe stands for suborbicularis oculi fat, okay? The fat that is below your orbicularis oculi muscle. So remember the anatomical dangers as well. So look at all the features, all the neurovascular bundle, your muscle and everything. So watch out mainly for facial vein and artery that end up is angular vein and artery at the middle angle of the eye. Okay, so remember we have a lot of retaining ligament. There are also changes. So we have all these vital retaining ligaments. They support your SMAS just like a trampoline. So when they slack, so your trampoline, your SMAS also slacks. So remember, the retaining ligaments also will have aging changes and they also need help. So these are the standard, these are the important ones in the mid cheeks, and they actually maintain the skin in its normal anatomical position. But with aging, they become slack, right? Yeah, so look at the lower third of the face. So typically a healthy skin, a healthy young patient, we have a very smooth and well-defined jawline. So we call it hockey stick, right? Nice hockey stick. But as we age, we lose the hockey stick. It becomes wavering, and with all of W's there, you see, then the shape of the chin totally changes and your mandibles becomes very tense. That's why in a lot of aging patients, I actually give PT into the mandibles and it does wonders. It doesn't change anything drastic, but it makes the chin looks more relaxed. Yeah. Okay, so in summary, aging process affect all the 5 layers. Yeah. Okay, so from assessment purpose, we always talk about the principles, the 3 pillars: anatomy, techniques, and also products. So remember these 3 pillars, you will never go wrong. So you must understand anatomy, good techniques, and also good products. Yeah. And when we talk about anatomy, there's 4D assessment. 2D is what our standard textbook teaches. And then 2D, we talk about the compartments and layers. So what is 4D? Right? So 4D is talking about dynamic versus static. Like I said, the superficial fat is the mobile layer, which is the dynamic layer, and the deep fat is the static layer, which is the non-mobile layers. So this is what we call facial dynamism. Why is it important? Because when you remember this and you correctly inject the correct thing into the correct layers, so you're going to respect the natural dynamism. You're going to have natural facial movements and also expressions. So patients will still look very natural, so they can smile naturally. So no one can tell that they have filler done, right? Okay, so remember your ATP, anatomy, technique, and product, and total facial dynamism in 4D. Okay, so quickly run through all the types of fillers we have. So hyaluronic acid filler is the main filler. This is a transient filler, temporary, completely biodegradable with Hyalase. And then we have other fillers like polylactic acid or Sculptra. Then you have Kaha, for example, Radius. Then you have PCI like Elonze. Then you have all these semi-permanent. So don't ever touch all these. These are not trending anymore. Those years when I first started, long time ago. Yeah, and that might don't touch them because they will lead to a lot of problems. They never biodegrade, they stay forever, and they don't age naturally with our face. And one day, patients gonna have problem, and they cannot remove them. So patient will come back to you after 5 years, 10 years. Look, you've done this filler for me, and now what to do? It's not nice. It becomes granuloma, nodule. So never touch anything that's permanent. Yeah, even though it seems like very attractive, very tempting for a patient because it's very cost saving, but never touch permanent fillers and always stick to natural fillers because they are biodegradable, right? The longer they last, anything that lasts very long bound to have more problem. Okay, these are the rheological properties. So, okay, very confusing. I just show you what does it mean by rheological properties. It means the behavior of the filler. So when you want to inject well into patient, you must understand your fillers. So you must understand their rheology. That means you know how they behave when you inject into the skin. Then you can choose the correct products, right? So you have your G prime, G double prime. So it just tells you how thick, how stiff, how much easy to flow, and how viscous the fillers are, so that you know which type to choose for which areas. Yeah, not all fillers are the same, right? So main thing, you want to know viscosity, means how much it can resist the flow, how easy for you to inject, and cohesivity means the vertical projection. So this is good for, like, you know, nose, chin, so because it can give you the vertical projection, so the ability to resist compression. Yeah, so generally the higher cross-linking level will be longer lasting filler. But I do not like very high degree of cross-linking because they use more chemical cross-linking agent, mainly is BDDE. So the more BDDE it has, it's cheaper, it lasts longer, and is very hard and very good for projecting, but they can also high chance of reactions, compatibility issues, and can lead to granulomas and nodules. Yeah, so try not to go for a very high degree of cross-linking. Okay, lastly, words of wisdom. Please do not use fillers which have no track records, and beware of all the blood thinning supplements that are taken before that, because they can end up with a lot of bruising. And then when you use needle, always use the smallest gauge. And if you use, must always keep the correct filler in the correct level of plane or layer of skin, right? And try to use a lot of ice after the treatment to prevent bruising and swelling. And certain areas we need some molding and massage, and never overcorrection. And of course, always do not rush and take your time, right? Okay, so techniques, when it comes to techniques, so you have all these various techniques, then your needle versus cannulas. And remember, needles always use small, and cannulas a bit bigger is better. I normally use smallest cannula will be 25G. I never use smaller than that. If I use 27G, it's not safe as a cannula. It behaves like a needle already, okay? So you understand that. And sometimes we need to combine both needles and cannula in one patient, especially when you do total face rejuvenation. Yeah, okay, so let's talk about eye. And for eye treatment, before you do, not every patient who comes in and you can jump and do their eyes, because some of them are no patients, yeah? So you want to evaluate the lower eyelid laxity. If they have too much, what happens? Do you inject when they have too much laxity? No, because you can aggravate the problem. So you must evaluate whether they have this lower eyelid laxity. So these are the tests that you can do, and make sure whether it's a tear trough problem, or whether it's a palpebral malar groove, or it's a combination of both. Yeah. So all right. So the techniques will require you can differentiate from indications from contraindications, and whether it's tear trough or the palpebral malar groove, or actually you correct the mid cheek. And when you correct the mid cheek, you can actually correct these two as well. And remember, tear trough is very thin, very thin, and especially in older women. And standard we have 5 layers in all the facial skin, but in tear trough only 3 layers. There's no fat, so there's only have bone, skin, and muscles in between. So only 3 layers. So you have to be very deep. Your injection should be just on the bone, very slowly and low amount, not more than 0.5 ml per side, because if too much, you will have the sausage deformity, right? So this is the anatomy. So we don't have time to watch this. Okay, so this is also the anatomy. Okay, now I show you some pictures. So look at this deformity. So they actually don't need to go for plastic surgery, and you can see the correct filler done with correct techniques can show so much improvement. And especially younger patients. Now this is happening in younger patients as well, because they have an abnormal sleeping pattern, and also they spend a lot of time with digital devices, so that will encourage the formation of tear trough as well. And so a lot of time they'll tell you, wow, it's such a life-changing experience, because they look so much better, because with the tear trough, no matter how much they sleep, it will still not improve. But when you have corrected the tear trough, even they don't have enough sleep, they will still look good, right? And they will tell you they can save a lot of time on eye makeup, right? Okay, so like this is a young patient. Look at this tear trough and the eye circle. So you see the improvement, right? See the before and after. And of course, there are always wrong indications where too much eye bag, too big, and exclusively just pigmentary changes, and a lot of lymphatic stasis, skin laxity. So these are no patients, right? Okay, so you can see this before and after patients. See, total face rejuvenation, even for men. You can see versus before versus after. You can see when he smiles, it's very natural, and he actually looks more friendly here, and here he actually looks a bit more upset, right? Okay, so we see before and after. Look at the improvement in the jawline and also the other eye. And so, okay, I just touched quickly on multi-layering technique. Yeah, the multi-layering technique means you use 2 type of fillers in 2 different layers. So one is superficial fat and one is deep fat. Remember, the deep fat is for structural support. So structural support, you use a stiff volumizer, so you have projection and lifting. So you lift all the overlying structures, so they get lifted. So now we have good facial contouring. So now superficial fat, So use the dynamic filler, means a malleable filler, very soft malleable filler. So it can fill up the lines and the folds and all, right? So this is what we call multi-link technique. It's very trending because it's very natural, and also it actually promotes more longevity, and also you can save the amount of fillers. Yeah, and so you can see some of the before and after. So you see the improvement. I say before and after, before, after. So you see before, after, you see.
Slow down, please. Can I see the previous slide before and after?
Oh, sorry. Okay.
Very interesting.
Yeah, before and after. So very natural, but you can see the obvious improvement. Huh? And even here, and then the jawline.
Quite subtle, but can see.
Yeah, this one not so obvious, but you can see the next one. Huh? Can see this one. So you see it's a bit baby here. You don't have a nice steady hockey stick. So this is a nicer, more steady hockey stick, right? This one is a bit baby.
But this patient is quite young, I would say, right?
Yeah, actually, when you look at the Caucasians, they age quite fast, much faster. So one advantage being Asians have it's a bit slow, but we have a lot of pigmentary issues. Yeah. Okay. Right. So you see before and after, see? Before and after?
Yes.
No difference. When you correct this jawline, it makes the patient look so much better, right? Okay, so and when she smiles, literally she maintains the same expression. Yeah. So this is what we mean by maintaining facial dynamism.
The crow feet also less.
Yeah, correct. Yeah, correct. The crow's feet also less and very natural, and she smiles naturally. And most importantly, you see very steady here, and here is like beginning to waver already. And then you see a bit of volume loss here and there. She's more steady here, right? Yeah. Okay. So all right. So last one is perioral. So these are all your standard terms for your lip area. So what is a perfect lip? So depends on different patients. So some want it full volume, very pouty. Some just want to be very subtle, well-defined, refreshed. So depends on patient. Soft volume versus full volume. And so these are all the things that we inject. We actually inject the lips and also the filtral column, perioral, the barcode lines as well. And remember, lips look so simple. People think the lip is so easy, just inject the lip. No, the lip is actually quite complex here. Look at the amount of muscles and the vascularities that are connected to the lips. So we have to be very careful with the lips, right? Okay, and look at before and after. So she looks very subtle, very natural, but so much better in the after compared to the before, right? Yeah, and so this is just 1 ml, okay? And look at this. So these are a bit of asymmetry, and she looks a bit inverted. So we want to invert a little bit, and so you see the results. So this is an inversion of the lip using the French kiss technique. Yeah, so she looks more balanced here, correct? So this is what we call facial harmony. It's pleasant, harmonious, symmetrical. Whereas this one is a little bit imbalanced, right? Okay, so look at the barcode lines before and after. Yeah, so see, so much better. So at least when you blow a kiss, your lines do not stand out so much. So people don't end up staring at you. Yeah, okay. So, okay, when we want to inject anything, we must always know the adverse effect. I'm going to run through really fast because this one is very theoretical. So I show you some pictures like edema, nodule, hematoma, gosh. So these are the things that we don't want to happen. And of course, standard, and sometimes they end up with abscess. If it's fluctuant, of course, you drain, aspirate, and then you give empirical antibiotics. And non-fluctuant, you just give empirical antibiotics anyway. And of course, when there's displacement migration, so we high list. That's why I emphasize on natural fillers. So you can high list them. If you use all this semi-synthetic or permanent filler, you cannot high list. You can't do anything to them, all right? And of course, the nodule and granuloma, very complex treatment, but if you're not sure, just high list them, okay? All right, so one complication very rare when it's tender erythematous worm. Look out for atypical bacteria, especially mycobacteria. This is very rare, right? Okay, so this is a very good summary, the differences between granulomas and nodules. And in summary, please, we do not want to cause abnormal anatomy. Don't over inject, and less is more. Not more is better, but less is more. Okay, and all fillers, even temporary natural fillers like HA, can cause reactions, but more so with those permanent fillers. That's why I always emphasize sticking to natural fillers, because not just, you wouldn't inject them permanent fillers to yourself, so I wouldn't inject for patients. And you also don't want patients to come back to you after 4 years. Maybe you want to retire, and then after 10 years, the patient come back to, look, this is the permanent filler you put in me, what to do now? And then you can't remove them, so you end up have to refer to plastic surgeon, right? Okay, and most complications are due to poor techniques, All right. And okay, lastly, very important to understand is your arterial supply, because we can have the most dreaded unwanted vascular complications. So the worst of the vascular complication can end up like this. So those days, patients did not know, doctors didn't know that this is actually vascular. They thought it was infection, but it's not. Look out for vascular. So arterial versus venous. So normally arterial will be blanching and venous will be dark colored. They look like bruise, yeah. And normally there's immediate pain for arterial, but not always. And it blanches and then become mottled and then become grayish black discoloration. But for venous, the pain is more dull, continuous, milder, and it was darkish, and there's more swelling. So that's the differences, right? And if you don't know what to do, always when you're preparing your Hyalase, you can get your staff to give a lot of warm. Never do cold, because then you shrink more vessels and there'll be more necrosis coming in, right? So always give hot compress, a lot of warm, and a lot of massage. So just keep massaging and get your Hyalase. So when you want to inject, always must have Hyalase standby. Yeah, no matter how much tonic, you must have it, because it can happen to anyone. Yeah, anything, anyone can happen. So with more experience, and then you inject, the more you inject, sometimes, you know, even your percentage of complication is so low, but the more you inject, the figures will go up. So always must have Hyalase. So anything if this thing happen, you're not sure, the best you can do for a patient, just Hyalase quickly. All right. Okay, and so what are the tips to reduce? So of course, aspiration, then you inject slowly, less pressure, and you keep moving. That's why we call, so we do retrograde injection, because as we withdraw the needle or cannula, so we inject. So your needle or cannula doesn't stay long in one area. So even if you accidentally in the vessel, you won't stay long there. So you won't end up giving too much, right? And for needle or syringes, use small, but with cannula, always use 25 and above. Don't use too small cannula, because it behaves just like a needle. And beware of patients who have done tissue surgeries or plastic surgery, because they change, their anatomy is changed. So you can end up with vascular complication. The vascularities and anatomy is changed. And sometimes patients don't tell the truth, or sometimes they forget. And sometimes they didn't think it was relevant, but you need to dig out. So as I practice so many years, I have my ways to dig out a lot of history from patients. All the aesthetic procedures that you do must have a very detailed past, not just medical, surgical, but aesthetic and drug history as well. Everything that they've done, yeah. So what they've injected, because they may have a permanent filler there. So it's quiet, silent there. And the moment you touch them with some new fillers, you might trigger the old thing and you might end up with some complications. And then they'll blame you. But they never tell, because they've forgotten about it, right? And then they've done some surgery. So you look carefully, there are some hidden scars, you know, because the anatomy has changed. So beware of this type of patient. You must always dig out the history from them, because most of the time they will not come, they will not volunteer, and they will not tell, they just say no, no, no. But you need to dig out the history, yeah, because this is to protect not just the patient, but to also protect yourself, right? Okay, and now we come to laser, finally. Okay, so are we still there for laser? Is everyone still awake for laser? Okay, so quick one on laser. This is the beam that heals, and laser stands for light amplification by stimulated emission of radiation. Yeah, and laser is wonderful. It can do so many things. And history of laser backdates to 1917 with Albert Einstein. And if you want to do laser, understand this spectrum, yeah, from gamma to radio, all this in between and all the different wavelengths. So understand this spectrum and understand all your different wavelengths and what are the hazards and what can happen. And also understand your chromophore absorption curve. Your main chromophores will be hemoglobin, melanin, water, and so all the hazards from eye to skin to chemical, electrical, toxic, explosive hazards, all this can happen. And of course, your personnel must be well trained, eye protection always for both doctors and patients. And then your room must have a warning outside and non-reflective instruments and no flammable materials, and always eye protection, topical anesthetic, but not always. And cooling is good, but not always. But for hair removal, it is almost mandatory, and always ice pack later, informed consent, and photography. Standard for all aesthetic procedures, like I said, you have to dig out the history in the past, whatever they've done, injected, and all the surgeries, and whatever implanted inside, you must find out, and always have a consent and photography, right? Okay, and beware of post-inflammatory hyperpigmentation, PIH, but also beware of post-inflammatory hypopigmentation, which also can happen. And when it's hypo, it is more long lasting. And remember, post-laser skincare is very important. Very, very important. And never trust patients. They tell you they have very, very gentle skincare and can be used. No, don't trust them, because most of the skincare in the market, they have some kind of whitening, brightening, anti-aging, exfoliation, and all. They contain some kind of fruit acids, no matter how mild or gentle it is. So they won't be suitable for post-laser. So you must always give them your post-laser skincare. Because you want to protect this, you want to maximize the outcomes that are desirable, and you want to minimize the complications. And for how long and what kind of post skincare, what to do, it all depends on the type of laser, type of treatment, the setting, what kind of setting are you doing, aggressive or mild setting, and then the skin condition, how sensitive the skin is, what's the Fitzpatrick skin type, and all the past history, like I told you, all the aesthetic past history, and also again, avoid all the exfoliative kind of products in the post-laser period. For those ablative and fractional, normally it takes 1 week downtime, so I will at least post-laser skincare for 2 weeks. But the non-ablative, normally I just post-laser skincare for 2 days only, yeah, because it's non-ablative. So we'll come to that later. And so this all the side effects. So whatever it is, the most important is the hyperpigmentation or hypopigmentation. Of course, the risks are higher with darker skin tone, right? And okay, these are the classification of lasers for LCP. So those of you who are interested, so you must understand lasers for skin pigmentation, for benign lesions, rejuvenation, and hair removal. So today, there are a lot of choice for hair removal, but it's our scope for today. Skin rejuvenation, we can do Q-switch. This is the main platform for skin rejuvenation because it is no downtime. It's soft laser, yeah, non-ablative. And of course, erbium and CO2 can be ablative, can be fractional as well, yeah. And then for treating benign skin lesions is always ablative, right? And skin pigmentation, you have choices of non-ablative and fractional. Okay, so we come to it. Okay, let's talk about pigmentation one. And mainstay is usually the Q-switch laser system for all this pigmentation. In summary, superficial lesions we use shorter wavelength, and deeper lesions we use longer wavelength. And be careful darker skin patients, yeah, because they can end up with hypopigmentation. And remember, for pigmentation, as a rule, things can recur. So never promise patient is a permanent result. So things can always recur. Okay, for skin rejuvenation, conventionally the gold standard will be CO2, and of course we have erbium yak now, and we also have non-ablative. My favorite for skin rejuvenation, especially for older patients and around menopausal years, we always use non-ablative because it's very safe. So you'll not trigger melasma, you also not trigger PIH, right? And also because these patients don't heal as well. And remember, don't fall into the tricks. Patient will tell, oh, I used to do a lot of fractional, I used to peel a lot, and that was 10 years ago. But now they want to repeat because they remember how good the results were. But remember, now their skin is not the same as 10 years ago. So you may not get the same, you may not get the same results, and you may also have got new complications. And when they've done successively too much of strong and harsh exfoliative whitening skincare sometimes outside, that will sensitize their skin already. So then your lasers can end up with complications. So be careful. That's why you must always find out what products they've been using, because in the market, a lot of patients actually use very strong product because they want the instant whitening. So this will sensitize patients as well. Yeah. Okay. So look at some pictures before and after. So this is what laser for rejuvenation can do. Yeah, you see before and after. Yeah. Okay, so now anti-yak laser, why I touch this? This is a touch solid state laser and wavelength 1064. This is very famous. This is one of the key items. So for those of you who want to do skin rejuvenation, this is best. And there's a lot of market for skin rejuvenation, 1064, right? And Q-switch mode means it's making the laser produce high intensity beam in very short pulses. So minimize the side effects, and also you get good results. 532 is more superficial, so there is a bit of downtime, but there's a bit of risk of PIH for 532. I rather use erbium yak actually. I'll come to that later. Whereas the 1064 is non-ablative. So what happens with 1064? So we talk about it because they work very well for pigmentation. And okay, before we go deep, be conservative. Don't be adventurous in lasers because lasers typically burns. So if you're too adventurous, you burn. And when you burn, you are scarred. So you have a lot of work to reverse and prevent the scars, right? So know your limits and understand your device. Just like you want to inject injectables, you must understand the behavior and the urology of your injectables. Same with laser, you must understand your device. But normally the company which you buy from, they will give you a training. So you must ask for the training, right? And you learn from your expert peers and network with them, and make sure check out all the contraindications and understand how to treat complication. Post-laser care, I told you, very important. And I told you the detailed past history, must find out, must dig out. And of course, there's always combination therapy, yeah? Okay, so look at before and after. So this fractional results, so before, after. See, look at the hand. Yeah, so you see so much improvement, right? And look at the face. Okay, so fractional laser. So now we come. So fractional, this is the history way back in 2003, fractional thermolysis. Okay, so not all of them are the same, different. In the late 90s and early 2000s, gold standard was always CO2. So you use this for scars, for wrinkles and facial line. But CO2 is gold standard. Why? Because it works well for the Caucasian skin, but not so much of Asian skin. Caucasian skin can really take CO2 very well because they're different Fitzpatrick skin type, right? So what happened is they remove epidermis and dermis, so there's a wound healing cascade. So you stimulate collagen and everything, so you have better skin and improve skin. But of course, there will be side effects. So the side effects is PIH, and of course, most problematic is hypopigmentation. Some of them can last really very long, and beware of that, right? So look at this. These are hypopigmentation, post-inflammatory hypopigmentation, right? Okay, so because CO2 is a bit too powerful, too strong, right? And it's very good for Caucasians, but not so much for Asians. So I use erbium laser. Erbium laser is it's an ally for CO2. It is competitor, but it's actually same efficacy but much gentle and more color friendly, skin color friendly, less downtime, less pain. So I actually use erbium laser much more. So you can have mode, ablative mode, so you can do all the removal of bulky skin lesion, and you can go into fractional mode as well. So fractional for scars, for rejuvenation, right? Okay, and so you see, fractional laser will target epidermis and dermis. So they deliver a laser beam that divides into thousands of tiny deep columns of treatment zones. We call this MTZs, micro thermal treatment zones. And look at the picture here. So these are micro thermal zones surrounded by healthy normal skin. So what happens? So you're not completely ablative. So this is what we meant by fractional laser. So because every treatment zone means the damaged skin here is surrounded by healthy skin. So that will help in faster healing. So you have faster healing process and less downtime. So the longer the downtime, more complication. The faster the downtime, less complication, right? So again, this is a picture. Yeah, so you see before and after, 2 days immediately, and after 14 days completely healed, right? Okay, so fractional laser can be used for fine lines, wrinkles, pigmentation, photoaging, scar, melasma. Can be used for any parts of the body, even can be used for stretch marks, right? And contraindication standard for all lasers, isotretinoin, no within 6 months. Cutaneous infections, also keloid, look out for their BCG scar, so you know what's the tendency of keloid, right? And also if they have a lot of exposure to UV prior radiation, autoimmune chemical pigmentation. Of course, when they do these procedures, you can also do laser, but you need to have a proper interval, right? And be conservative again, like I said before. And remember, fractional laser is very trending now. It's actually the gap between ablative and non-ablative, yeah, for both sun damage and aging skin. So ablative means you remove. So this is what they use when you want to remove things you do not want on the skin, you want to remove warts, moles, all the keratosis. So they work mainly on epidermis. And non-ablative, I call it soft laser. They go straight into the dermis. They do not damage the epidermis, right? They go straight to the dermis. They break down the melanin and all. They work on the melanosomes. So it's very good for rejuvenation and pigmentation. Fractional is in between. So it works on both epidermal and dermal. Yeah, so you have a choice of ablative, non-ablative, and fractional, which is a gap between these two. All right. So for older patients for rejuvenation, I tend to use non-ablative. Only for bulky skin lesions, nothing can help you. Only you have to do ablative, but that's only for spots, right? So the recovery will be faster. But overall face, I'd rather do non-ablative because it's very safe, especially when they're around menopause and they have a lot of sun exposure and they already sensitize their skin because in the past they've gone everywhere jumping from salon. So every salon will try to be very aggressive, so they overdo, they sensitize. So these are very sensitive patients. So they PIH very easily. So I avoid fractional for them. But when they are younger and they have a lot of scars and the skin is healthy and more virgin skin, then you can do fractional because fractional give you faster results, right? Okay, so you understand the difference. So look at what fractional laser can do. And of course, fractional is wonderful for Caucasian skin because they can literally do a lot of things. Their skin is much more tough, right? So before and after, you see all this picture. Okay, lastly, chemical peel. So literally means we peel away the years, right? So it started with lactic acid from sour milk and goes on to other things. So it just means control damage. We control the accelerated exfoliation of skin by the agents that we want to use, all right? So remember, if you want to do, again, you understand your Fitzpatrick skin classification, understand all the various types of peel, the proper selection, and what are your aims. So you want to understand the types of peels, patient selection, so you have maximize your outcomes and you minimize complications and treat complications. Yeah. All right, and so you have AHAs, glycolic, tartaric, and all these things, and normally endpoint redness, and there must be frosting. No, sorry. When you see frosting, you have to immediately neutralize. The endpoint is erythema, and initially you need to neutralize. Yeah, and BHA normally no need to neutralize because it's self-crystallization, self-neutralization. Yeah, and this one mainly for oily and acne skin as well. And then you have TCA. TCA is actually very good. Again, endpoint frosting. You must see frosting. When you see frosting, that's the end. You don't need to neutralize them, and then you have a lot of other acids, right? So remember, the depth of the pills can be influenced by the agent, how much the concentration, how many layers of passes, and what kind of skincare you've been using, and also by patient's skin type and pill interval. Yeah. So these are the history. Watch out for keloid, active herpes, sensitive skin, those with history of atopic dermatitis, photosensitivity, those patients who are on retinol is a no-no, those who go for very aggressive facials, some salons they do very aggressive, those who just done threading and waxing for hair removal, you have to wait for a while. And also informed consent photography. So identify all those problem patients, right? And all the standard contraindications. And of course, lastly, microdermabrasion. Microdermabrasion is generally a physical treatment, very mechanical, right? So it started in 1940. It's called dermabrasion. So it's too harsh using wire wool, but later it became very fashionable. It becomes very fashionable treatment, either using crystal or diamond head, and now includes oxygen infusion, like so many, very fashionable now. Some of them even include massage and RF2 all in one, right? And it's actually a controllable treatment. You can adjust and control your setting and your techniques and the passes, right? Okay, and a very good machine to have, especially for those who are starting out, because it's very safe. It doesn't burn, right? And it can literally use on all skin type, all color as well, right? And of course, you always have your standard contraindications, but because it's so mild, it only affects the epidermis. But of course, there will be a suction, and they also give you a bit of stimulation for the dermis. So you do get some result, but of course, you not drastic lah. So there are limitations for certain conditions, yeah. So you either use crystals, aluminum oxide, or use diamond head. Okay, I personally love this when I first started many years ago, more than 15 years ago. And it's very good for young patients as well, and very safe, and you can train your therapies to do. And I prefer the crystal because it's much safer compared to diamond head, because diamond, if you're not careful, sometimes you end up scratching the face, right? Okay, and now finally, skin tightening devices. This is also one of the modality in the LCP for doctors, for GPs, and it generally means that we use a lot of targeted energy to deep heat the layers of the skin, because with the heat, whatever energy you use, you heat up the tissues, you will stimulate collagen and elastin production. So what happens? So you increase in your elasticity and also your firmness, right? And there's so many machines that can deliver this kind of things, and a quick, minimal downtime, comfortable, no scars, and literally doesn't burn unless you don't move your handpiece. If you stay there too long, of course, you might end up burning, but if you keep moving, you will not burn, yeah? And of course, it's also part of the electromagnetic spectrum, and there are many types of radio frequency. Now, some of them are more advanced. They are add up with they include microneedling. Finally, we have ultrasound. So these two are covered in LCP for GP. So ultrasound, art therapy, or HIFU, right? And radio frequency, many types, such as Venus, Legacy, Thermage, and so many more. There's influx of RF machines from Korea. They are very cheap, yeah. But I use mainly American radio frequency because I found they are much more reliable and they don't spoil too fast, yeah. And remember, there are 3 types or 4 types: monopolar, bipolar, unipolar, or multipolar. So monopolar means deep, yeah. So they will cause some fat loss actually to the more deep and more suitable for body. Bipolar is more superficial, more for face, and multipolar is in between. So there's differences, right? Okay, and but beware of side effects, especially those high powerful radio frequency, because it's high energy, it can cause some pain, like Thermage. It's painful. Art therapy is also painful and can cause fat necrosis, remember, yeah? And of course, you can cause atrophic scarring, burn, and crusting, especially if you don't move your handpiece, right? And now the latest fractional also using microneedling system, 2-in-1, right? And contraindications, remember, ask patients if they have any medical devices, especially pacemaker. Yeah, so Betty will tell you, no, don't touch these patients. You don't mess up with their pacemaker, okay? And those autoimmune and anyone under radioactive treatment and recurring herpes infection, don't do RF for them, right? And finally, that's all. So I managed to cover all. So sorry it takes so much time, but I tried to cover all that is listed for the LCP for GPs, right? Yeah.
Amazing so comprehensive. I'm so sorry I could have made it into 2 sessions, but it was very interesting. Are there any questions, please? So, now people are coming in younger and younger
Yeah.
for all this aesthetic, and it is not so much. It is not so much what, right? The fact that they want to look young is they want to change the way they look, right?
Yeah, sorry, hang on. Wait.
Okay, Alvin said, wow, that was a very informative session by Dr. Christina, and all her works look so professional. I have definitely learned a lot. His
Yeah.
question is, may I know what is the requirement to get into aesthetic medicine?
Okay, first and foremost, forget about all other qualifications. You need your LCP, so the licensing and credentialing privilege. So all the requirements are listed in the MOH website. So you need to have your logbook. You need to complete 3 years of service and 3 years post-graduation. And then you start to accumulate your cases, and then you have to sit for assessment, and then I think they have an interview or something. And then when you pass, you get your LCP. So it's renewable on every 3 years. And it's also listed in the national NSR for medical practitioners, for registered medical practitioners practicing aesthetic medicine. Yeah. So you'll be listed in the NSR for registered medical practitioners practicing aesthetic medicine. So you must aim to get your LCP. Yeah.
So
There are
you
many.
train, is it? You train them. You do this training, right?
Yeah, I do. I train them under other organizations. So there are many organizations, there are a few other academies. Some doctors, they actually start their own academies and they train doctors for this purpose. So you join whichever that you're comfortable with. So you see what's their track record, who are the trainers. So I train for MAC, I train for Powers, Texane, and Triple AM. I know MAC does have very good program, but it really depends on who are the trainers. So you just do some homework, and some doctor you don't have to, but you don't have to join these courses because they are expensive, but they do help. Yeah, they're actually very helpful because they give you chance, because you are so tied down with your work. So when you go for practical part 2, yeah, so we actually have live session, we actually have real sessions. So we do live demo and a quick run through, and then we actually guide them. So we really let them do hands-on. So when they finish hands-on, they can actually sign all these cases in their logbook, so they can fill up their logbook. And each treatment, right, each type of treatment, they need to have 20 to 25 cases. Yeah, so you see, sometimes it's hard. Where are you going to find? You don't even have a laser machine. So how are you going to do for 20 cases? So when you sign up for these workshops, right? So when you go for the workshop, you do, so you can also you observe your colleagues' cases, you also do your cases, so you can add up all the cases, so you can fill up your 20 to 25 cases. Yeah.
I see. Oh, the laser you can try on me, anyone.
Yeah.
Laser, I'm not so scared.
Yeah, for Beppy, anytime. For Beppy special, anytime.
The injection, how do you get it like symmetrical? I mean, you see, you're so used to inject one side, and then the other side is like the contralateral side is your hand. You know, the it's very difficult, right?
Yeah, I know what you mean. Yeah, because I sometimes use right hand, sometimes I use left hand. So it depends.
Also, you have to be ambidextrous.
No, not necessarily. Yeah. So when I inject right side, I will be on patient's right side. So then on the left side, I will actually go to the other side. So the bed you must put in the middle of the room, so you can move around the patient. Sometimes we actually do from the back, sometimes we do from the right, sometimes we do from the left. Yeah, and sometimes because of the direction, I'll be standing on patient's right side, but I'm actually injecting her left side. So you see, sometimes I need to do that depending on the direction of the needle and cannula of the injections. Yeah, so you must be versatile, but it doesn't matter whether you are right hand dominant, left hand dominant, you will adjust to it. But most important, you must be able to move freely around the patients.
Well, it was a very comprehensive I wish that we could have broken up into 2 so that you didn't have to rush so much.
Yeah, I thought of it last minute, but I thought, oh no, it's okay. So I just try to cover as much as possible.
Yeah. And next week, Christina is coming back again. And this time we are doing a body contouring, right?
Yeah, body contouring. Yeah. If there's any request for any repeats for today's session on next week, so just let me know if I can slot it in. Lah. Yeah. Because for body contouring,
Not much, is it?
less lah, less. Yeah.
Okay.
Yeah. So
Uh,
these are non-surgical body contouring. Yeah. Mm.
okay, how painful are all these injections? How
Okay, most of the fillers, they are already pre-mixed with lidocaine. So it's actually really much less painful. When I started more than 15 years ago, they were without lidocaine. So you can actually feel the filler going inside. But now you don't feel anymore. And the first injection, you feel a bit. After that, it becomes numb because there's already lidocaine. And then the more I do,
is
you have
so
no more pain.
clever?
Yeah. So it's very much tolerable. In fact, it can be a lunch hour procedure. And we do properly, the pain actually is quite minimal. Mm.
How about the Botox then?
Botox depends. If you do intramuscular deep on the glabella area, that's where they always say most painful. Yeah, but when I do intradermal for crow's feet, there's hardly pain, very little. But you have to be very careful because crow's feet is the easiest to bruise because the skin here is thinnest. And we always use ice. So very cheap, you always use gloves and fill up with water, then you freeze them and they become huge chunk of ice pack. So you just ice them and they become so numb. Then when you inject, you don't feel anything. So
Oh, you don't use any LA or
for Botox, I mean for the botulinum toxin, we just use ice pack. We don't need to use numbing anesthetic cream. But for fillers, yes. For fillers and all the intradermal and all the multiple injection point, I will always put the anesthetic cream. So I put anesthetic cream for at least 30 minutes to 45 minutes. And if they are very scared, I can do a few times. So I do 15 minutes, then I clean up, my therapist will clean up and repeat again. And then we 2 or 3 rounds, so they become really numb. And then when they do filler, the first filler goes in, they feel a little bit. Then after that, the more filler goes in, the more numb because there's more lidocaine inside. Yeah. And then when I do mid cheek here, after I finish, their lips are numb. Then if you do the lips, it's very comfortable. Yeah, because you already hit all these nerves here. The some of the lidocaine already numb your nerves here, so you can actually do perioral with very less pain.
so you must have tested a lot of these products on yourself.
Reasonable amount for myself to try to maintain. Yeah.
And who would do it for you then?
Some I can do myself, some I go to my colleague lah. Yeah.
I see, I see.
Yeah. So I personally tried most of them, so I know how they feel.
Oh,
Yeah.
yes.
But we don't do too much, like it's more regular maintenance. Yeah, because less is more. Not more is better. No, that's not true, but less is more. So that's why I say using the correct product at the right plane, in the right patient. Yeah, so that's why I emphasize on all the aging process, all the 4D anatomy. So you put the correct product at the correct places, you can get optimized results and using less fillers. So you can
So,
save costs.
a lot of these GPs can actually train for this, right?
Yeah, they can treat, but to be safer side, you must have LCP if possible lah. Yeah, but still a lot of them practice without LCP, but it's better to have LCP or you work with someone who has LCP. So you are actually under supervision with the doctor with the LCP. Then along the years, you acquire your experience and you go for courses, you go for workshops and learn as much as possible. Then when you pass your exam, you got your LCP, then you can be independent. Yeah.
Okay. So maybe if anyone wants Christina's email or whatever, do contact her.
Yeah, be free to contact me. You can
Yeah,
add me on Facebook or
okay.
Instagram, so you can always message me. Yeah.
Yeah, it's very, very amazing, especially the layers, the information you gave us.
Yeah,
And you-
because I train a lot. I very highly detailed into all the different areas. So I just try to condense everything today to give an overview. Yeah.
Oh my God, it was very, very detailed. Okay,
Yeah.
so this pigmentation, I'm gonna ask you, is the use of the medication, what is it called again? Oh, yo,
For pigmentation,
yes, for pigmentation. An
Cyspera, is it?
the oral medication.
Oh,
Tranexamic.
tranexamic acid, right?
Yes, it is
Yeah.
very useful, right?
Yeah, it does actually. Yeah, it works a lot for melasma patients. The truth is it works. But when you stop, the melasma comes back. I tell
Yes.
patients melasma is just like your hypertension or your diabetes. When you treat, you control, but when you stop, they come back. Yeah, because 3 factors, aging, hormonal, and sun. Yeah, so even you control the sun and you manage your hormones, but the aging is still there. But of course, like I said, we put in all the anti-aging therapy. Then of course you can minimize the melasma, but there's a lot of maintenance lah.
Okay, is there any evidence that weight in the more you weigh, the faster you age?
Yeah, indirectly it's true. So let's say you notice a lot of aging and you don't want to do anything, so you wait another 2 years, so you add another 2 years of aging, so there's more, and then you finally come for treatment, so there's more work involved. Yeah.
No, I'm talking about weight. A person that's overweight.
Overweight. Oh, sorry.
Yes,
Yeah.
not weight.
Yeah.
Overweight.
For anti-aging therapy. So
No, yeah, as in a person who would age faster if they increase their weight, they're overweight compared to a person who is normal weight.
yeah, actually generally quite true. Generally, yeah. For women, so their hormones also can go haywire when they're too fat, because all their female sex hormones are fat-loving hormones, so they'll be lost in the fats. Yeah, so then they have hormonal imbalance. Yeah, so I tell them, even the guys will tell them lose weight. So if their hormones are imbalanced, lose weight before they actually start them on hormonal treatment. But sometimes with all these hormonal imbalances secondary to weight gain, they find it really hard to lose weight. So sometimes we have to go in and really, have to help them to lose weight and do a bit of anti-aging for them. Depends on how much they prioritize anti-aging. Yeah, how much they are willing to spend as well, and how disciplined they want to follow.
Yeah. Okay. I want to put some thought into anti-aging.
Yeah.
I want a good hockey stick.
Yeah, hockey stick. We all want a hockey stick.
I've never done anything.
You look good, Betty. For someone
I'll come and see you.
More than anything, it's good.
Okay, I'll come and see you. Okay, I see you next week then.
Okay, yeah.
Teen ladies, Dr. Ng said teen ladies has more wrinkles. Obese ladies have smoother skin. I'm not sure about that, That's why I asked this question. Because people say, oh, you can't lose too much weight. If not, you will age. I feel like, in actual fact, if you actually maintain your weight, you will look younger.
Yeah, true. You do not want to lose too much of volume from the face, regardless whether you're overweight or not. Don't lose so much of no drastic loss of volume from the face, because when you lose volume, then you have all these sunken areas. Then you lose the facial harmony and the proportions. Remember all these rules, huh? Yeah. Then you look aged, no? Then you have to fill up, no? Regardless whether your body is overweight or thin. Some patients who are thin, but they don't have drastic losses, so they're still okay. So it depends.
Right? I think genetically also very important, right?
Yeah, genetics as well. Yeah, and then the lifestyle, all these things. Some patients are overweight, but then they have hypertrophic, they're explosive kind of aging. So they have heavy folds, wow, and heavy nasolabial here, all heavy. Well, these are also very hard to treat. Yeah, because there's too much of volume. So doesn't mean too much of volume is good. It depends case to case. Yeah.
And then this the skin being lax with aging is a problem, isn't it?
Yeah, skin laxity is the main issue. That's why a lot of treatments now are targeted for skin laxity. Yeah, sometimes we do skin laxity treatment on the surface. Just that already you can improve a lot, but it needs to be constant. You need to maintain, because every day we are aging, every minute we are aging. So you want to reverse that, you also have to maintain. Then you also have to counter the ongoing aging. Yeah, so so I always tell patients, don't start too late, because it costs more when you start late, and there's more work to do. Right?
Oh, I see.
Yeah, because you start too late, there's already more damage. So there's more work to do to reverse all this. There's more things to reverse. So there are more skin laxity. And sometimes they come on the skin so lax, I need to do a lot to reverse. But if they come earlier, there's less work to do. And then they just need to maintain after that. Yeah.
Oh.
Yeah. Those patients, yeah, because of that, they come so advanced aging, but there's so much work. thankfully, those who can pay, then we can do, but there's a lot of work involved. Yeah, but if you come earlier, before too much of aging has set in, so there's less work to do. Then after that, you just maintain lah.
Can I know how much money would it cost most times?
Too general question. Depends on what they want.
Okay, okay.
Yeah, too general. Depends. Some of them just want to work on the neck, yeah, because they have some turkey neck here. So okay, the cost is just here. Some they want to treat the whole face, and then depressed here. They're so bad lines, and then they're so sunken. There's so much work to do. Yeah, and then after that they can't sleep. Then you have to correct those as well. Then they have bad lifestyle, and then their diet is bad. Their nutritional levels.
You are like
Yeah.
you are like a coach lah, like a life coach to them then.
Yeah, I will share my personal experience. Yeah, so I try to encourage them to, because for men and women, especially for women, so when they take good care of themselves, they actually empower themselves. Yeah, and then you feel good. I mean, you look good, you feel good, and then you feel empowered. And then they, productivity also better. Then they feel better about themselves, a lot more lah. And then it goes back to their relationships as well. It improves. Yeah. So overall, it's better. Yeah.
Okay, thank you so much. I want to see next week what contouring can be done. I'll try to lose weight. Next week, maybe I'll be slimmer.
Oh, you have nothing to lose. You're good.
No, quite a lot.
Yeah.
Okay, thank you, everybody. Thank you so much. You're so comprehensive and there's no questions. Everybody is just saying, okay. Everybody is just saying thank you.
Oh, I see. Yeah. Oh,
Okay.
Yeah.